Assalamu alaikum. This is the first lecture of dermatology. I'm Dr. Sitwat, and we will start with the basic terminologies because the anatomy and the histology has been done by the anatomy department. Okay, so when we describe a skin lesion, it is important to note the following features. What is the size of the lesion, the type of the lesion, the shape of the lesion, symmetry, color, pigmentation, surface area, distribution over the body surface, because you can see the skin lesions. Type of the skin lesions are divided into three: the primary, secondary, and the special. Now, what do we mean by the primary, secondary, and special? Primary lesions mean the basic patterns of skin with a definite morphology. That is, they arise de novo. There is no pathology before that. Secondary lesions arise either as a development of the evolution of the primary lesions or by manipulation of a person, like scratching or secondary infection. And special lesions are those that are specific for certain diseases, like comedones are specific for acne, burrows are specific for scabies. Now, there are different types of primary lesions: macule, patch, papule, plaque, nodule, vesicle, bulla, pustule, abscess, wheal, cyst. What is macule? It's a flat circumscribed lesion showing just a change in color without any change in the consistency. Macules are not palpable. That is, it's a diagnosis of inspection, basically. You can just see the change. If you just palpate it with your eyes closed, you won't be able to feel any abnormality there. Macules are 0.5 to 1 centimeter in size, and they may be of different colors: brown, blue, red, hyperpigmented. For example, we can see this is a nevus. Nevus is a pigmentation like a mole. Freckle, that is also just like a that is a macule. That is there is no marking present on it, and there is no feeling present on it. Fixed rug eruption, caffeole, which are birthmarks. Then Mongolian spot, that is seen in newborns. It's a blue-colored macule. Blue nevus is also a macule. Ink tattoo is a macule. Then red-colored macules, drug eruptions, secondary syphilis. These are all impalpable. Hypopigmented in tinea versicolor. You're going to understand all these terms once you know all the lectures. You have gone through all the lectures. Right now, they may be seeming a little bit different to you, but later on, you will be able to understand. Tinea versicolor is basically a fungal infection. Now, when we increase the size of the macule, it becomes a patch, more than 1 centimeter in size. It may have a little bit of scaling. It may not. For example, vitiligo, melasma, pityriasis alba. Papule, if we raise the macule with the same duration of, with the same diameter, like less than 0.5 to 1 centimeter, it becomes a papule. It's raised above the surface of the skin, and hence it is palpable. And it may again be of various colors, just like the macules. Can be flesh-colored, yellow, white, like molluscum, skin tags. Can be brown-colored, like of melanoma, dermatofibroma. Can be red-colored, like acne, folliculitis, insect bite. Can be blue-colored, like a blue nevus, like lichen planus. These are basically, lichen planus are basically more violaceous or purplish in color rather than blue, but still it's the same family. Then plaque. Plaque is an indurated area of skin which is larger than 0.5 centimeter in diameter and which is usually raised above the surface, but may be sometimes depressed below the skin surface. Examples of plaques are psoriasis, lichen planus, and tinea corporis. Pityriasis rosea, seborrheic dermatitis, tinea pedis, eczema, they all are also examples of plaque. Nodule. Nodule is large, like 0.5 to 5 centimeter size, firm, raised, and raised above the surface. But the thing is that it is just like a papule if you just observe it, but it is the depth of involvement that differentiates a nodule from a large papule. Nodule can have a different consistency. It can be warm, soft, fluctuant, movable, fixed, or painful. And it may have a different texture of the surface, like fungating, ulcerated, keratotic, smooth. Examples of nodules are basal cell carcinoma, hemangioma, prurigo, neurofibromatosis. Other examples of nodules are xanthoma, keratoacanthoma, and melanoma. Now, vesicle. Vesicle is a small fluid-filled lesion. less than 0.5 centimeter in diameter and raised above the plane. It has clear fluid in it, and the lesions are translucent, so you can see that fluid inside, like chickenpox and herpes zoster. Now, when the other examples are impetigo, insect bite, herpes simplex, dermatitis, herpetiformis. When the nodule becomes a bit larger, it becomes a blister. And when it becomes really larger than 5 centimeter, then it becomes a bulla, which is fluid-filled, raised, often translucent lesion. Examples are bullous pemphigoid and the fixed drug eruptions. Pustule. Pustule is a small-sized vesicle which is not filled with clear fluid, it is filled with pus. And it is formed due to the collection of inflammatory exudate, which are rich in leukocytes. It may contain bacteria or may be sterile. For example, acne pustules, so pustules of the psoriasis, folliculitis, and scabies. Abscess, a localized collection of pus which is deep in the dermis or subcutaneous tissue, and it may be surrounded by inflammatory reaction. That is, the skin may be red, hot, tender, and due to its deep-seated location, it may not be visible on the surface of the skin, but may show signs of inflammation. Now the wheal. Wheal is a transient swelling of skin which disappears within 24 hours, and it is formed due to sudden extravasation of fluid in the dermis. For example, urticarial wheals. Urticaria and dermographism are examples of wheals. Cyst. Cyst is a spherical or oval sac, encapsulated cavity containing fluid or semi-solid material. Now, what is the difference between a cyst and a vesicle or a blister? Cyst is lined with true epithelium, so it's not easy to rupture it. You have to excise it to remove it. For example, mucus retention cysts. Then we come on to the secondary lesions: scale, crust, erosion, fissure, sinus, scar, atrophy, lichenification. What is a scale? Excess dead epidermal cells that are produced by abnormal keratinization and shedding. For example, the psoriatic scales, the ichthyosis. Then scales can be of different types. Fine to stratified, what happens? Just fine scaling over it, or very large silvery white scales of psoriasis. Then the ichthyotic scales, which are like the fish scales. Then tinea versicolor has fine briny scales, which is just like powder present over the tinea. Then scaling in these sheets like desquamation is present in the scarlet fever, shown on hands and feet. Then crust. What is a crust? Dried exudate of body fluids, blood and serous fluid, which might be either yellow or red. Then examples of crusting: tinea capitis, or the crusting seen in impetigo. Erosion. It's a focal loss of epidermis. Erosions do not penetrate below the dermoepidermal junction, and hence they heal without scarring. Erosion is usually longitudinal, like tinea pedis, candidiasis, eczema, herpes simplex. Ulcer is a focal loss of epidermis and dermis, and this crosses the dermoepidermal junction. When the erosion becomes deeper, it changes into an ulcer. And definitely then there is scarring, like chancroid, pyoderma gangrenosum, decubitus ulcer, or the ulcer of bed sore. Chancroid, it's a sexually transmitted disease. Just observe the type of the lesion here. Pyoderma gangrenosum, and then the decubitus or the bed sore ulcer. Radiodermatitis. Sometimes there is ulceration secondary to the radiation that is given after a malignancy. Fissure. It's a linear loss of continuity of skin due to excessive tension. For example, eczema of the fingertips and intertrigo. This is an example of fissure, intertrigo, and the fingertip eczema. Scar. It is replacement of the normal skin tissue by the fibrous tissue in the process of healing of damaged skin. Scars can be of two types: hypertrophic and atrophic, like occurs in acne, burns, herpes zoster, and keloids. Scar of herpes zoster and the burn scars. What is a keloid? It's an area of overgrowth of the fibrous tissue that usually develops after healing of the skin injury and extends beyond the original defect. This is the difference between a keloid and a hypertrophic scar. Then what is atrophy? It's a reduction in size and number of skin lesions. It may be limited to the epidermis, dermis, or the subcutaneous tissue. For example, atrophy secondary to leprosy, atrophoderma, and the lipotrophy. It can also be seen by after injection of insulin. Lichenification. Lichenification is repeated rubbing of the skin, which results in thickening and hyperpigmentation of the skin. The skin markings become prominent, like in lichen simplex chronicus, atopic dermatitis. Then there are special lesions. Special lesions means those that are present in specific diseases like burrows, comedones, milia, telangiectasia, poikiloderma, purpura, and infarcts. Burrow is a serpentine or snake-like tunnel which is made by the scabies mite in stratum corneum. The open end of the tunnel has a papule. Comedone, we talk about comedogenic acne. The comedones are the blackhead and the whiteheads. So comedones are tiny plugs present at the opening of the hair follicle caused by the keratin and sebum. Obstruction is caused by the keratin and sebum. It is of two types. Open comedones are the blackheads, and the closed comedones are the whiteheads. Milium, plural is milia. Very common tiny superficial cysts with epidermal lining. So they are true cysts. You cannot really rupture them. Milia are often seen periorbital, and they occur due to obstruction of the epidermal eccrine duct. Telangiectasia, the visible dilatation of capillaries of the skin which blanch on pressure. For example, seen in dermatomyositis, systemic sclerosis, and prolonged use of potent steroids on thin skin. Poikiloderma is a combination of reticulate telangiectasia, pigmentary change, and atrophy. For example, dermatomyositis, poikiloderma of Sitwat. Purpura, the basic pinpoint ones are the petechiae. The middle-sized ones are purpura, due to extravasation of red blood cells from the cutaneous vessels in skin and the mucous membrane, and the largest ones are ecchymoses. On diascopy, they are non-blanchable. Diascopy means you take a glass slide and you try to press on the lesions, and they do not blanch. They do not become pale. Okay? Then infarct, area of cutaneous necrosis, tender, irregularly shaped, dusky red-gray macule or firm plaque. Then this is just an animated picture of the different types of papules and nodules. Papule is usually dome-shaped, for example, trichoepithelioma, flat-top verruca plana, plain warts, umbilicated molluscum contagiosum, a punctum present in the center. Acuminate, that is a special, what you can say, filiform or um, hill-like, mountain-like, condyloma acuminata. Verrucous, different types of multi-peaked lesion, like in viral warts, verruca vulgaris. Then we come on to the second part of the lecture, the infestations. Common infestations are the scabies, lice, and leishmaniasis. Scabies is a contagious parasitic disorder occurring in epidemic form. It is caused by Sarcoptes scabiei, which is a mite. It is caused by the female Sarcoptes scabiei, to be accurate. Fertilized female burrows into the skin, laying eggs in the stratum corneum, and they hatch 3 times to become the adults. And they repeat cycle every 14 to 17 days, and the adults wander onto the skin surface to form new burrows, and they usually move at night, and this is the cause for the nocturnal itch. And it affects all ages and sexes. Clinical features: severe itching nocturnal, more than one family member is affected. Characteristic lesions are burrows on the skin, grayish linear C-shaped or S-shaped lesions present. Usually ulnar border of hands, wrists, elbows, axillae, umbilicus, buttocks, penis, breast, and nipples are the common sites. Complications: secondary infection, obviously, like impetigo, boils, ecthyma, eczematization, particularly in infants, persistent itchy post-scabitic nodules, especially in the males, adults and boys on the scrotal area. Then the diagnosis is confirmed by scraping a burrow with a scalpel, warming it with a few drops of 10% KOH, and then observing it microscopically for the acarus or the eggs. Nocturnal itching and involvement of more than one family member is very suggestive. The differences include generalized pruritus, papular urticaria, atopic dermatitis, impetigo, infected malaria, and interruptions. Treatment: treat the patient along with other family members. Treat the whole body below collar. Use medications for 2 days only in a week. Launder clothes. Treat scabies first. Treat scabies and complications both. It's basically, it depends on the condition of the patient. Sometimes the complications are so severe that we have to treat them first and then the scabies, because the anti-scabitic lotions sometimes give a stinging effect on raw areas. Suppose they're infected or impetiginized, so the scabitic lotions become stinging. So we have to treat the complications and then the scabies. But tell the patient that he has to return for the treatment of the actual scabies and not go away after getting treatment of the complications. Then benzyl benzoate lotion, gamma benzene hexachloride, sulfur ointment is very good but messy. Monosulfiram lotion, protometone, anti-pruritic agent, malathion, permethrin. Permethrin is the drug of choice now. Lack of compliance, insufficient treatment, reinfestation, or overtreatment may lead to the failure to improve. These are the reasons why a patient says, I'm taking the treatment but is not responding. These are the pictures you can see: infected scabies, the pustules present, especially in the web spaces. Then lice. Lice is called as pediculosis. Two species of lice parasite on man: pediculosis hominis, occurring on the head and the body; pediculosis capitis and pediculosis corporis. This is the same lice that affects the head and the body. Then there is another variety, the Thyrus pubis. You can see the difference between the shapes. These are elongated type of lesions, and this is a bit of plumpish, stoutish type of lesion, right? This is also called as the crab louse, and this is the pubic lice. Pediculosis hominis is grayish-white insect that sucks the blood, and the female lays eggs lifespan 7 to 10 days, to 7 to 10 eggs per day. Eggs are called nits. They are oval capsules firmly cemented to a hair. Most of you may have, especially the girls, may have gone through this phase of the lice infestation. This is very common during the school age because of the longer hair of the girls. Most commonly confined to the scalp, rarely involves the beard or other parts of the body. Population is highest in the occipital and the preauricular regions. Women and children are more commonly affected. It may be transmitted via sharing combs, headgears, etc. Itching is more marked in the occipital region and the side of the scalp. Secondary infection with suboccipital adenitis. It's very common. Like the lymph nodes get enlarged for any area of the body where there is infection. And these may be the presenting complaints. Sometimes the patient's parents come and they say that there are lymph nodes enlarged in the neck, for example. In the cervical lymph nodes are enlarged. And the patients immediately come to the diagnosis, is there a malignancy? Is there a cancer? And they come with that. And when you take the history, you come to know that the patient is suffering from lice infestation. Nits on occipital region resemble scales. Hair may be matted together with pus, producing foul odor. Foul odor. Okay, the diagnosis, you can see the treatment: gamma benzene hexachloride, permethrin again is the drug of choice, malathion, carbaryl lotions. Pediculosis corporis usually affects older men and women, normally occurs in persons who are not normal, persons who are unable to maintain their hygiene, persons who are mentally not stable, who are bedridden. For example, patients of Alzheimer, patients of coma, patients of CVA, that is stroke, paralysis, patients who are bedridden due to, suppose, some fracture. Usually, body lice is seen in those patients. Head lice is seen often in normal patients, but body lice is seen in patients who are affected mentally or are unable to take care of their hygiene. And they definitely do have scalp lice as well as the body lice. The body lice lives in the seams of the clothes where it lays eggs, and it is transmitted through the clothing or bedding. Clinical features include small or persistent papules at the site of bites. Secondary infection is common, and pigmentation in chronic cases occurs. It's called as vagabond's disease. Vagabond basically is an English word for avara, because it can occur anywhere all over the body, and it usually occurs in people who are insane. You may have seen people roaming around the roads with dirty clothes, not changed for long time, hair rough and matted, not mentally sane. The diagnosis is confirmed by looking for the lice in the seams of the clothing. Treatment, delousing of the bedding and clothing, local antipruritic, for example, calamine lotion, topical antibiotics for secondary infection, and then the actual treatment of the scabies, of the lice, as mentioned in the scalp treatment of lice. This is picture of lice. Then pediculosis pubis. Infestation is usually by sexual contact. The main habitat is the pubic hair. However, it may be found on the hair of the thigh, abdomen, axillae, eyebrows, very rarely on scalp. It is called a scrab louse. It has got a different type of um, hands, you can say, for grasping the pubic hair, which have a different texture. Intense irritation, later secondary infection or eczematization may occur. Blue-gray macules or maculae cerulae may occur. Heavy infestation may be associated with fever, malaise, lymphadenopathy, and leukocytosis. Diagnosis again confirmed by finding the lice in skin. Treatment is the same for any other type of pediculosis. Papillary urticaria is an insect bite reaction. Topically affects young children, especially on the exposed portion where the insect must have bitten, like small red ants or mosquitoes, often grouped together, intensely itchy. It's an urticaria, but there is a central punctum or a point where the insect has bitten, usually due to the bite of flea, bedbug, mosquitoes, midges, and lice. Papillary urticaria is uncommon before the age of 2 years due to less sensitivity, but may occur in infants as well. Irritable wheals, recurrent crops, exposed parts like hands, feet, arms, legs, and lower legs. Secondary infection is common. Treatment prevention against insects by using insecticides. After lesions have appeared, you have to treat the actual lesions, and oral histamines are very useful. This is picture of papillary urticaria. Then we come on to the last part of the lecture today, which is third type of infestations, not that common as scabies and lice. This is leishmaniasis. It's a different variety of disease infestation, focal distribution present all over the world. New World lesions are present in the South America. Old World are present in Asia, Africa, Middle East. It is transmitted by the sandflies. New World, Leutzomia, and in Old World, phlebotomus. This is just a picture to show which type of leishmania variety is present in which type of country, in which country. You can see that looking at the colors. Okay, there are different types of leishmaniasis. New World, cutaneous, mucocutaneous. These are mentioned, the different organisms, the subtypes that give rise to different types of leishmaniasis. Again, geographical distribution, and this is the picture of the vector. There are three types of leishmaniasis clinically: cutaneous leishmaniasis, mucocutaneous, and the visceral. We basically deal with the cutaneous and mucocutaneous because they have skin involvement. The visceral leishmaniasis often does not have skin involvement, and it has generalized organ involvement within the body, and this may prove fatal as well. The cutaneous leishmaniasis is the most common form, relatively benign, self-limiting skin lesions, simple variety. Mucocutaneous may have skin involvement, and then if the skin around the body orifices is involved, it can change into the mucocutaneous. Okay, so it is the promastigote that is transmitted from the sandfly to the humans. In the humans, the promastigotes, the cycle or the life cycle of promastigotes takes place in the human, and amastigotes are formed. Then the amastigotes are transferred if the sandfly takes a blood meal from the infected patient. And the cycle of amastigote takes place in the sandfly. Same thing, promastigote life cycle in the human and amastigote life cycle in the sandfly. And there are some animal reservoirs like the rodents. Promastigotes, phagocytosis by macrophages, they're converted into amastigotes. Amastigotes replicate within the macrophage rupture, release amastigotes. If the sandfly takes a bite at that time, then the amastigotes go inside the sandfly and complete the life cycle. Symptoms and pathology associated with the leishmaniasis result from the amastigotes killing the host cells. That is, it's basically the host cell's inflammatory response that is responsible for what type of leishmaniasis is going to take place. The best competent, you can say, a host produces simple cutaneous leishmaniasis. That is, the leishmaniasis remains limited to the site of the bite. The poorer the immunity, the more widespread the reaction. Old world cutaneous leishmaniasis caused by usually Leishmania major, moist cutaneous ulcer-like lesion, usually not painful, very clean cut ulcer and not responding to the regular treatments. Surrounding zone of inflammation. It may heal by itself in 2 months, 2 years, leaving a depressed, unpigmented scar with a lasting immunity. It is transmitted by the phlebotomous species from rodents or human to human. New World Leishmania mexicana. The ulcer usually heals spontaneously in a few months. However, where the bite occurs on the ears, it can lead to chronic lesions, also known as sclerosed ulcer. Because the cartilage of the pinna is poorly vascularized, the immune response is weak here, resulting in mutilation of the pinna. You can see the picture here that the pinna is mutilated, right? It is found principally in the Central America and Mexico, that is the South American areas in the forest areas. Cutaneous leishmaniasis is usually localized to the site where the sandfly bites. Again, the same thing, the amastigotes multiply in the reticuloendothelial system. Incubation period varies from days to several months. If kept clean, the sores will heal spontaneously within 2 months to 1 year. However, they may be site of the secondary infection, resulting in permanent disfiguration. Once the infection has been cleared, the host is immune to reinfection by the same subtype. In some regions, this is a sort of localized vaccination method that the people, the residents inoculate their children uh, in non-visible sites. So, and the child gets a disfigured scar in that non-visible site, the covered parts of the body. And the children get immunity, long-lasting immunity, lifelong immunity from that particular variety, which is prevalent in their part of the world. Typical versus atypical. Typical cutaneous leishmaniasis, as I told you, the ulcer clean cut type of lesion. And this is atypical. It looks more like leprosy, not like leishmaniasis. Then mucocutaneous leishmaniasis, inoculation of promastigotes by the bite results in red papule, ulcerates. It's caused by Leishmania brasiliensis. You can see by the name that's more common in Brazil or the South American area. But the promastigotes may spread from the bite via the lymphatics. There's a metastatic spread. The disease is called as spondia, and it may involve the nasal and buccal mucosa, causing destruction and malformations of the cartilage and the soft tissues. You can see this. You can see this, right? The ulcerations can involve the nose, pharynx, palate, and lips. Invasion of the larynx may result in a loss of speech. In Brazil, 1/3 of the spondia occurs in children, and it may take years for it to spread from the initial site of the bite. And secondary infections and respiratory complications may cause death also. Epidemiology is extremely diverse. 20 Leishmania species are pathogenic, and 30 sandfly species are proven vector. Old World phlebotomous type, New World Leutzomia species. Zoonotic and urban type. Zoonotic is from animal host in the transmission cycle, and the urban is mostly human to human. Diagnosis of all types suspected because of the geographical presence of parasite, history of sandfly bite. Often the patient doesn't even remember a bite in history. In our part of the world, in Pakistan, usually interior, Balochistan, and even KPK. Patients come from these areas and they have a history of sandfly bite. They often tell you that they went to the village and when they returned, they developed this lesion. Often they don't even remember the bite, if any. Then presence of skin lesions, chronic painless clean ulcer, nasopharyngeal lesions or nodular lesions, then demonstration of parasite in the skin lesion, or if internal organs are involved, then in the aspirate from that, delayed hypersensitivity reactions and serology. Serology, amastigotes may be seen in the scrapings, biopsy, and aspirates. In vitro culture, we can do for the pre-mastigotes and inoculate into hamsters. This is not normally done. Then How to take scrapping? Make incision in the active part of the lesion. Active part is the border. And then we see it under the microscope after mounting. And you can see the first one, Leishmania tropica, from an impression of biopsy of specimen from a skin lesion. This one, what do you see in this one? Intact macrophage with practically filled with A mastigotes. All these are A mastigotes. And they have visible clear nucleus and kinetoplast. In the second picture, the macrophage is rupturing and the A mastigotes are being released. In the third one, 3 Leishmania A mastigotes are seen clearly enlarged with a visible nucleus and a keratinoplast. Control in epidemiology obviously depends on the local transmission, avoid sandfly bites, bed nets, netting, insecticides, destruction of the dog reservoir, Tropica vaccine, as I told you, local inoculation that the residents do in the covered areas. Then for the New World, zoonotic, arboreal mammals. Arboreal means those mammals that live on trees. They are also reservoirs. Okay, lowland forests, occupational. In the New World, urban, dog is the reservoir. In the rural area, rodents are the reservoir. For the visceral, in the India, human fly, human is the life cycle. In Pakistan as well. In Africa, rodent is the reservoir. Other parts, dogs with lesions may be the usually reservoir. Basically, the problem is technical, managerial, financial, and political constraints. There is no recognized cost-effective control packages. Issue is that the countries that normally face these are developing countries or underdeveloped. So economy is an issue. We need the tools for testing, for the parasitology, for prevention of the disease, for avoidance of sandflies. So the treatment of the visceral leishmaniasis by first-line drugs is long and expensive, and poor compliance often leads to increased unresponsiveness. Vector control by spraying houses with insecticide is not sustainable. You cannot just keep on spraying every time. You have to sustain it somehow. Animal reservoir control is expensive and difficult to implicate. Efficacy of dog culling is questionable. Other constraints, lack of well-trained technical personnel, weak delivery systems, education, awareness, political, financial commitments. It's very important. It's a disease of poverty, and the patients are the poorest among the poor. And obviously, when they don't have enough to eat, how are they going to look after their health? Control programs, again, rural endemic foci, humans colonized areas, parasite moved into domesticated dogs, and cases in humans become more common. Endemic areas, each of these different types of situation requires different approaches to control. We have to control vectors, we have to try to have protection versus bites. Rather, that is, prevention is better than cure actually. So we should try to get the patient avoid being bitten rather than treating the bitten and looking after the bitten patient. Treatment of the infected persons, elimination of the reservoir, and vaccination where possible. Thank you.